Okay, well, I think we'll make a start. It's 12:05. So welcome everyone to pediatric teaching today. Today I wanted to talk about an infection that is not very commonly diagnosed, but actually is quite common in PNG and in the Pacific Island countries, and it can be a relatively simple infection that can be treated fairly easily with antibiotics, and it can be a more complicated infection. And often we think of periorbital cellulitis as being an infection that maybe the ophthalmologists look after or something, but I've we've had some recent cases where it's been very important for the paediatricians to have a very good knowledge of periorbital cellulitis and the differences and the early detection of complications of periorbital cellulitis, because the consequences of the complications are very severe. And I wanted to start by um, I'm sure you've all seen a case of periorbital cellulitis. It's a inflammation, a redness, swelling around the orbit of the eyelid, and it's usually accompanied by fever, and sometimes accompanied by other systemic features of infection or illness. Um, Usually, if it's uncomplicated, the child doesn't look very septic. They have the swelling around the eyelid, and and as I say, they respond quite well to antibiotics. The cause of periorbital cellulitis is very similar to the cause of other respiratory infections in children, bacterial respiratory infections in children, and that is because the etiology of periorbital cellulitis is often very similar to those other respiratory infections like pneumonia, and it relates to the colonization of the nasopharynx and the with bacteria fairly early in life. And as you probably know, the children in PNG and Pacific Island nations are quite densely colonized with bacterial pathogens in their nasopharynx quite early in life. And they may have one or more pathogens, and the common causes of periorbital cellulitis, well, certainly historically, the most common cause was Haemophilus influenzae type B, and that it's a bit less likely now that children are commonly immunized against Haemophilus influenzae type B. That certainly in other countries it made periorbital cellulitis that we used to see very regularly, it made that infection largely disappear. But there are other bacteria that cause periorbital cellulitis as well. And Streptococcus pneumoniae, which is the common cause of pneumonia, also a common cause of periorbital cellulitis. And then some periorbital relates to scratches or insect bites on the eyelid, and that can lead to a Staph aureus periorbital cellulitis, and that's also quite common. And then there's some other bugs, bacteria, including Moraxella catarrhalis, which is just a nasopharyngeal pathogen that also causes some pneumonia, and it can cause some periorbital cellulitis. And then there's another bug called Streptococcus aeruginosus, which is a oral streptococcus. It's commonly colonized in the throat in people in countries everywhere, and that can sometimes cause periorbital cellulitis. And then very rarely, mycobacterium tuberculosis can cause periorbital cellulitis. I emphasize that it is quite rare. And the top three pathogens I've mentioned, Haemophilus influenzae, Streptococcus pneumonia, Staph aureus, are the big pathogens. And of those Staph aureus, then unfortunately at the moment we need to be aware of methicillin-resistant Staph aureus being a not uncommon community-acquired infection. I wouldn't say it's very common, but it's not uncommon when a child gets a staph infection, and we just need to be aware of that because the antibiotics we've traditionally given for periorbital cellulitis might not work quite as well. I wanted to talk about periorbital cellulitis because I want you to understand about the complications and how to detect them early. And to understand the complications of periorbital cellulitis, you need to understand the difference between two types of infection. And one's called periorbital cellulitis, where the infection is of the eyelid and surrounding the eye. And the other is orbital cellulitis, where there's infection below the orbital septum. And the orbital septum is a thin sheath of fibrous tissue that goes between the orbit and the eyelid. And that separates the eyelid externally from the orbit itself. And within the orbit is the globe, the globe. Within the orbit is all the extraocular muscles, and there's a lot of periorbital fat. So the eye globe sits in um, periorbital fat, and the muscles and the nerves that supply the eye are within the orbit, obviously. And so when in periorbital cellulitis, the only part that's infected is the eyelid. You get edema, inflammation, redness, swelling of the eyelid, and the eyelid may even close and be difficult for the child to open their eye. But what the key to this is to understand about the periorbital septum, the orbital septum, which separates the periorbital space with the orbital space. Orbital cellulitis, on the other hand, involves the orbit itself, and so it can involve inflammation, infection of the periorbital fat, of the muscles themselves, of the nerves, and the bone of the orbit. So those four structures within the orbit may be infected, and you can already see that while periorbital cellulitis is a form of cellulitis, just a skin infection, then orbital cellulitis or orbital infection is a much deeper infection that can lead to complications and development of pus within the orbit, and that's a much more serious problem. It's a little bit like the difference between cellulitis on the skin and osteomyelitis more deeply, or pyomyositis or septic arthritis more deeply, where you've got cellulitis of the skin that's going to respond very well to antibiotics. If you've got a deeper infection, and in this case going deeper to the orbital septum, within the orbit itself, in the fat, in the muscles, in the nerves, in the globe itself, then you've got an infection that's much less likely to respond. And making that distinction between the two is very important. And to make that distinction between the two, periorbital cellulitis and orbital cellulitis, sometimes it's called pre-septal, which means in the front of this, at the front of the septum. So just the eyelid and the skin around the eye. These children have normal vision. They don't have blurred vision because the nerves going to the eye are not affected, and they don't have ophthalmoplegia. They're able to move the eye in a normal way, and they don't have proptosis. Their eyelid may be swollen, but the eye globe is not swollen. And the way to see that is to look down on the child from above, and you can see whether their eyes are more protruding on one side, on the affected side, than on the other. So those three things: normal vision, no pain on eye movements, and no proptosis. Now, I think these are three features that are often taught, but actually they are quite hard to examine in a child, especially a child who's got a swollen eyelid such that they can't open their eye. It becomes quite hard to know if they've got proptosis or if they've got pain on moving their eye. And if they're a young child, it becomes hard to do so. But they're the three clinical features of periorbital cellulitis and not orbital cellulitis. Whereas orbital cellulitis, if you've got a child who's got pain on eye movements, if they've got ophthalmoplegia, that is their eye is the globe doesn't move in a conjugate way with the other eye, or if they've got double vision, or if they've got proptosis, then they are at great risk of orbital cellulitis, an infection in the post-septal space in the globe itself. In children who've got periorbital cellulitis, it's a relatively localized infection, and those children may have a high white cell count and they may have fever, but usually they respond quite well to antibiotics over 48 hours to 72 hours. Their fever should come down, the inflammation should get better, the swelling gets less, they start to be able to open their eye after 24 or 48 hours. the children that have got orbital cellulitis, this won't occur to. And because of the infection that's deeper, they'll then not respond. Their fever will stay high. Their blood, their full blood count, full blood examination will look more toxic, have more neutrophils, or it won't be responding in the way that you'd expect a child who's got periorbital cellulitis. And trying to make this distinction, not just at the time of presentation, but each time you see the child is very important to detecting complications early. Periorbital cellulitis usually results from one of two things, either a scratch or an insect bite around the eye that leads to infection of the skin, or sometimes if a child's got bacteremia from any cause, it might be bacteremia from pneumonia, or bacteremia from the skin, or bacteremia from an infection in some other location, even the throat, then that the bacteria, just the same as bacteria can lodge in the distal end of bones, causing osteomyelitis, they can also lodge in the periorbital tissue around the eyelid. That's the origin of periorbital cellulitis. Orbital cellulitis, on the other hand, is usually a complication of a sinus infection. And yeah, the ethmoid sinuses are adjacent to the globe. And if you've got ethmoid sinusitis, like pus in the ethmoid sinuses, then there's a risk that will extend to the periosteal bone and then cause an infection of the globe itself. And that's the common origin of orbital cellulitis. So this so-called post-septal cellulitis, or cellulitis that's behind the orbital septum. Sometimes it's direct trauma to the eye. If a child has a penetrating eye injury, then they're quite likely to get orbital cellulitis. If they've got an infection of the tear ducts or the teeth or the face or the ear, then sometimes that can spread to the orbital space. And sometimes if periorbital cellulitis is not treated promptly, then the child will develop orbital cellulitis from that. It'll spread beyond the septum into the globe. In just the same way. And what that leads to is an abscess or an infection behind or around the eye or in the bone. So I'll show you some scans of children that have got orbital cellulitis, and you'll hopefully be able to see what I'm talking about. The studies that have looked at, large studies that have looked at children with periorbital and orbital cellulitis, it's not surprising what the clinical features are. All of them have periorbital edema and inflammation, and about 23% have pain on eye movement, which again is indicative of orbital cellulitis. 15% have chemosis, which is just redness and inflammation of the eye, again suggesting an infection that's deeper than the orbital septum. 10% have proptosis, that again is consistent with orbital cellulitis. 10% have ophthalmoplegia, 5% have diplopia, double vision, and a smaller proportion have reduced visual acuity. I think it's hard to assess visual acuity in these patients because they've got an eye that's closed and often can't be opened, and they have to be old enough to be able to say whether they can see something or whether they've got normal color vision or not. These are two children that have got periorbital cellulitis, and the challenge is to know when and whether they've got orbital cellulitis. They're two different children, and the first child here looks like he has got proptosis, doesn't it? Always a little hard to tell, but he looks like he's got proptosis, and he's certainly got a well demarcated inflammation around the eye, and clearly his eye can't open. And the other child looks like there's swelling not only of the eyelid but also to the side of the head and the cheek. And so sometimes these patients, they get from periorbital cellulitis, they get a facial cellulitis, and it involves the soft tissues of the face as well. As in these two children, they have a form of facial cellulitis, and you might notice that this child's got quite a swollen hand. So he's got infection in another place as well, which is the hand. These are, if you want to make a distinction between periorbital and orbital cellulitis, then the best way is if you can do a CT scan. Now, not everybody can do a CT scan, and the clinical features are the most important. But these are the features I talked about, where you can see that the left is on this side, on the left side of the scan, and this is the right eye. The right eye is normal, but the left eye is proptotic, is pushed forward, and you can see that the periorbital fat and soft tissues surrounding the eye are rather more inflamed. You can see how swollen the soft tissues surrounding the eye are. This is the muscles surrounding the extraocular muscles, and you can see that they're all edematous. Compared with this side, where the extraocular muscles are quite fine. The child's got mild left proptosis, and you can see, just have a look, these are the ethmoid air cells, and normally they look like this, black being full of air. But if they're full of pus or full of fluid, then they'll be grayer, all right, grey, or they won't be black like they're full of air. So anything where there's black, that's air or water. Fat contains a lot of water, so that's why that looks black. But you can see that there's swelling of the muscles. So this is clearly orbital cellulitis. It's gone beyond what would be periorbital cellulitis. This is another CT scan, a different patient, and what you can see here is, again, the ethmoid air cells are opaque. They're not air filled. The ethmoid air cells are opaque, and if you look at this membrane here, which doesn't exist here, this is the normal fat within the orbit, and you can see that there's very little fat. The black is fat, but there's very little fat. There's a lot of soft tissue inflammation in the left orbit, and actually this is like an abscess, what's called a subperiosteal abscess, because the periosteum goes along is adjacent to the orbit, and you'll see how swollen that area is. So there's an abscess in the subperiosteal region of the orbit. The left globe is proptotic, it's pushed forward, and the anterior ethmoid cells are opaque, so suggesting there's fluid there and likely pus. But this is a orbital cellulitis with a intraorbital abscess, and clearly needs draining if the child's going to get better. This is another child where the right eye has a ethmoid abscess. This is the ethmoid air cells. You can see them air-filled on the left side, but on the right side, they're grey. So they're full of fluid, and the fluid must be pus, because there's a collection of pus in the subperiosteal region. So again, a similar thing where the infection is spread from the sinuses to the orbit, and again needs drainage to be for the child to improve. You can see that this is if you couldn't see it before, then that's the outline of the abscess. There's a classification of these types of complications of orbital cellulitis and orbital infection, and that's called Chandler's classification. It's not very sophisticated. It just is that group 1 types of infections have pre-septal cellulitis, that is in front of the septum, just involving the eyelid, and group 2 are different forms of orbital cellulitis, and there may be infection in the periosteal region, like we've seen. There may be infection adjacent to the globe, or a pus adjacent to the globe, and then a further extension is if it extends beyond the orbit into the skull base, where the cavernous sinus is. And the cavernous sinus is like a vein that drains the brain. Blood drains into the cavernous sinus, and cavernous sinus thrombosis is a form of septic abscess that occurs within a vein. And if a child gets a cavernous sinus thrombosis, then they're at great risk of stroke from that. And so a severe periorbital cellulitis that leads to orbital cellulitis is likely to lead, if not properly dealt with, if not drained and get the right antibiotics promptly, that it may lead to an intracranial extension, and that can lead to cavernous sinus thrombosis, and that can lead to strokes. And unfortunately, that's what happens to some children, if they don't get combination of medical and surgical treatment early. The treatment for these patients is mostly medical. 70 or 80% of them, they will get better if you treat them with ceftriaxone and flucloxacillin, or if you suspect MRSA, then covering that with vancomycin or linezolid. Mostly, they get better with ceftriaxone and flucloxacillin. And that works in about 70 to 80% of cases where there's no evidence of orbital cellulitis, and you get onto it fairly promptly. But about 20 to 30% need a combination of medical and surgical treatment. And I tried to explain the origin of orbital infection, because you notice that the origin of the orbital infection is mostly from the sinuses. And that's why it's good to involve the ENT surgeons, because if they need drainage of an abscess within the orbit, then oftentimes what they need is drainage of an ethmoid sinus abscess. And if you drain the sinuses, then oftentimes the orbit can be, the infection that's spreading to the orbit can resolve. So these children don't always need to have ophthalmological drainage of the orbit. Sometimes they need just sinus drainage, and sometimes they need a combination of both. Both the ENT surgeons have to drain the sinuses, and the ophthalmologist may have to drain an abscess within the orbit. But oftentimes all you need is the ENT surgeons to drain the sinuses, and then the rest of the infection will clear up. Some post-septal infections, if they're involving deeper structures, they don't form an abscess, and they can be still treated with antibiotics. So not all the orbital cellulitis need drainage, but all the orbital cellulitis need assessment to see whether they should be drained or not. And that assessment will be based on the severity of illness and ideally a CT scan to see if there's pus there. The risk if the abscess isn't drained is, as I said, intracranial extension, and it's cavernous sinus thrombosis, because that cavernous sinus just sits at the base, at the sort of the posterior part of the orbit. And if you get an infected clot there, then that's a very serious complication. It can lead to stroke, and it often leads to a frontal cerebral abscess or meningitis in these patients. And it's a common reason why, unfortunately, children with periorbital and orbital cellulitis die. If they die, it's usually because of one of these intracranial extension of these infections. And so we want to pick up these patients before they develop that complication, and have the ENT surgeons and the ophthalmologist look at them. So all these patients need to, I think we need to have some rules for escalation and referral. And they include, if a child's got any of the clinical signs that I mentioned there, in the ophthalmology field, they're referred to as grave eye signs, serious grave eye signs. And that is proptosis or ophthalmoplegia or blurred vision or chemosis. Now, as I said, in children, it can be hard to tell those things. So we need to use all our powers of examination, good clinical examination to see whether the child's got those features. And if they're present, then urgent ophthalmology review. And in fact, I think all children with periorbital cellulitis need to be reviewed by an ophthalmologist if you have one. And if not, then assessing for these grave eye signs is very important. They all need treatment with antibiotics. And if you give ceftriaxone and fluclox for 2 or 3 days, then there should be improvement. If they've just got periorbital cellulitis, there will be an improvement. But if there's no improvement, then they need referral for an urgent CT scan and review by ENT and ophthalmology. And that depends on the resources that you have at your hospital. But you can't leave a patient with orbital cellulitis without that escalation, that referral for a CT scan to see if they've got pus in the orbit, to see if they've got a periosteal infection, or to see if they've got sinuses that are packed with pus that need drainage. So how do you know if the child's improving? Well, it's fairly obvious. They have resolution of their fever within about 48 to 72 hours. They have reduced eyelid inflammation and swelling, and they often, then they can open and move their eye. If that happens, then the child's responding to the antibiotics well and they're getting better. But importantly, we need to know how to know if a child's not improving. And you need to look for those early eye signs, those grave eye signs on a regular basis, at least every day, and sometimes a couple of times a day. And to know whether the child's got persisting fever. Again, the fever should effervesce. If they've got worsening eyelid swelling or inflammation despite 48 hours of antibiotics, then something's going wrong, and you need to be alert for that. These signs, some signs are quite late, and certainly proptosis is a late sign because you've got to have pus behind the eye pushing it forward, as is generalized sepsis, or don't wait until they've got neurological signs of a stroke or a meningitis or a cavernous sinus thrombosis. Let's try to pick these patients up earlier if we can. And I must say I wanted to talk about this today because we had a recent case, a very sad case, and sadly this patient didn't make it. And these are 3 pictures of the child over the time, about a week of treatment. And you can see that the swelling and the evidence of orbital cellulitis is getting worse each day. And we need to try to pick these patients up as early as possible. This patient was in a place where the paediatrician looked after him very well, but it was very hard to get that ENT opinion, the ophthalmology opinion, and the availability of a CT scan wasn't there. So it is very hard to manage these patients, but I think we can probably be a bit more alert to, the signs of orbital cellulitis or the lack of response to therapy, and hopefully be referring patients earlier before they get the worst features, if you like. So the message of this talk, this quite short talk, I think, but I think it's an important talk to have this discussion. We need to recognize these patients early. We need to treat them urgently with antibiotics. It is an urgent infection. Even periorbital cellulitis is an urgent infection. So treat them with the right antibiotics early. We need to make every effort to distinguish between pre-septal and orbital cellulitis, pre-septal and post-septal cellulitis. The role of CT scan is very important. If things are not going right, then refer the patient for a CT scan, and refer if the child's not improving, or if they get worse at 48 hours, because 85% of them will need surgical intervention either by ENT or by ophthalmology or both. And let's not wait until those late signs of intraocular extension appear or neurological complications appear if we can. So that's all I want to say today. I think it's we haven't talked about periorbital cellulitis before, and I think it's an important infection that we see quite commonly, and we don't always have ophthalmologists or ENT surgeons to sort of rely on taking over the patient, and we have to manage them as best as we can. So that's all I want to say today. I'm going to stop sharing my slides and happy to answer any questions that you might have.